Good evening, everybody, and welcome all of you to the 66th live webinar on orthopedic principles. And good morning to all those who are watching it from the United States. Today, we have guest of honor, Dr. Savyasachi, or simply called Savya Thakkar, from Johns Hopkins, Baltimore, United States. Dr. Thakkar is a hip and knee reconstructive surgeon serving patients in Baltimore, Maryland, and Washington, D.C. metro areas. His expertise is mainly on minimally invasive hip and knee surgery, including partial and total hip and knee replacements, outpatient joint replacement, and complex revisions after previous joint replacement surgery. Dr. Thakkar uses computer and robotic assisted techniques for these procedures to provide cutting-edge care to patients with hip and knee arthritis. Currently, he serves as assistant professor of orthopedic surgery at Johns Hopkins. Dr. Thakkar completed his medical degree at the Johns Hopkins University School of Medicine and stayed for his residency again at the Johns Hopkins. He was the first recipient of the Donald P. Byung Leadership Award as chief resident. He continued his training as a knee arthritis and traumatology fellow in Switzerland, followed by an adult reconstruction fellowship in New York. He then pursued the prestigious European Knee Society Traveling Fellowship, focusing on advanced surgical techniques and management of arthritis. Dr. Thakkar's research interests include technological advances in the treatment of arthritis, post-traumatic arthritis, the economic impact of arthritis, and the optimization of hospital protocols for arthritis management. He's also interested in exploring same-day joint replacement surgery, minimize time in the hospital, and maximize return to function. So today, it's my great honor to introduce you to Dr. Savyasachi Thakkar. Over to you, Dr. Thakkar.
Thank you very much, Dr. Gopalan, for including me in this dynamic lecture series, and we're going to talk this morning in Washington, D.C., but evening in India. So good evening to everyone who's joining us in India on the spine-pelvis relationship, especially from the perspective of a hip surgeon. And this is a fairly complex topic that's gaining a lot of traction, and I was hoping that we could cover some basic principles. I have no relevant disclosures for this talk, but this is our beautiful hospital in Baltimore, the Johns Hopkins Hospital, and I'm very privileged to be a part of the orthopedics department there. And I welcome whoever would like to come and visit us. So, when we think about the spine and pelvis relationship, we have to kind of go to the proverbial chicken and the egg. What came first? Was it the chicken or the egg, or vice versa? And I invite you to think about a paradigm shift. We really have to think about the egg as a boneless chicken. So we have to combine these principles to really understand how the spine affects the pelvis and vice versa. And we have to work together with our spine surgery colleagues sometimes to appropriately place implants in these patients to prevent complications. And I'll go over some of these complications in some of my later slides. The sacropelvis junction is a very complex junction because it's the link between the axial skeleton, which is the spine, and then the appendicular skeleton, which is the pelvis and the lower extremities. So changes in one frequently affect the other, and it's a very dynamic relationship, as highlighted by this video, which was developed in Lyon, France. So in this, you can see that the sacrum will be attached to the spinal column, as you can see here, and the spinal column is a very mobile unit with multiple joints across the spectrum. There is a sacral slope, which then defines where the spine and pelvis lie. And as the sacrum moves in this sagittal plane video, you can see how the spinal curvatures are changing. Now, switching to the coronal view, as the sacrum moves side to side, once again, the spinal curves have to compensate for the sacrum. The sacrum, fortunately or unfortunately, is attached to the pelvis. So now as the pelvis moves side to side, again, the spinal columns have to adjust in a compensatory fashion. And this relationship also exists in the sagittal plane. So this is a complex three-dimensional relationship in terms of spino-sagittal and spino-pelvic balance. So today what we're going to do is we are going to look at some spinopelvic measurements I will start by defining these measurements with regards to a spine surgeon, and then I'll take it with regards to a total hip surgeon, because we have similar nomenclature, but we look at this from two different perspectives. So it's like two sides of a coin. Then we will define what exactly is the meaning of acetabular anteversion as it means to the spine surgeon and as it means to the total hip surgeon. Then we will look at some examples of sagittal spinal balance and imbalance. And finally, we will discuss the implications for total hip, and I will demonstrate 3 cases to go over some of these principles. So these are the 3 critical spinopelvic measurements that we all need to understand. And most of the times, these are used by spine surgeons to define balance or imbalance. But even as hip surgeons, we should at least understand the basic principles. The first one is the sacral slope. Then we have the pelvic tilt and the pelvic incidence. The pelvic incidence from amongst these is constant, and any changes that happen keep the pelvic incidence constant, but changes will be in the sacral slope and the pelvic tilt. So let's define these. The sacral slope is defined as a line drawn from the top of the sacrum along and a line drawn horizontal, and the angle that is formed by these 2 lines is defined as the sacral slope. And this is where the sacrum meets the lumbar spine and defines that junction. Pelvic tilt is defined by a line drawn vertically north or vertically towards the head from the center of the femoral head in the sagittal plane, and another line drawn from the center of the femoral head to the center of the top of the sacrum, the proximal aspect of the sacrum. And that angle is known as the pelvic tilt. Finally, pelvic incidence is a line drawn from the center of the femoral head in the sagittal plane to the center of the proximal aspect of the sacrum, and another line drawn along the sacral body. So this value is what remains constant. Now, if you look at this, the pelvic incidence, once again, I'm going to draw it out for you. It's the line down the body of the sacrum and connecting it to the femoral head from the center of the sacrum. The pelvic tilt, as you can see here, is the line connected by the center of the sacrum to the center of the femoral head, and then one drawn vertically north towards the head. And finally, the sacral slope is a horizontal line to the slope of the proximal aspect of the sacrum. As you can see, the relationship of this is that the pelvic incidence equals to the pelvic tilt plus the sacral slope. So it's the sum of the pelvic tilt plus the sacral slope. Pelvic incidence averages about 50 degrees. So the range is from about 48 to 53 degrees, and it's fixed in adults. In children, it's still moving, but in adults, it's fixed. So any kind of compensatory movements have to happen by alterations in sacral slope and pelvic tilt. But we don't really understand these when we're doing a total hip. So let's define this further. Now, what is the relationship between the spine and pelvis, and what's considered balanced and unbalanced? So Schwab looked at this and published this in 2013. For this, we have to measure the Cobb angle for lumbar lordosis. So you take L1 and you take L5 and you draw lines along the superior aspect of L1 and the inferior aspect of L5, and then you draw perpendicular lines. And the angle that is connected by these or is made by these perpendicular lines is called lumbar lordosis. So ideally, the lumbar lordosis should be within 10 degrees of the pelvic incidence. So the ideal sagittal balance is when you have a pelvic tilt that's lower than 22 degrees, and the mismatch between the pelvic incidence and lumbar lordosis is less than 10 or 11 degrees. So that's when you know that the spine is well balanced. And this is an example of spinopelvic mismatch, where the lumbar lordosis in this case is approximately 22 degrees by the Cobb angle technique, and the pelvic incidence is shown to be 65 degrees. So there is a greater than 10 degree mismatch, and this is typical of a flat back syndrome where adequate lumbar lordosis has not been restored in the fusion construct for this patient. Now, those were the spine terms, but we have to really look at terms for the acetabulum and terms for the pelvis. So now let's switch our roles from spine surgeons to hip surgeons, and we have to look at acetabular anteversion. Acetabular anteversion can be defined in several different planes, and I have a pelvis model with an acetabulum fixed into it. So if you're doing a posterior lateral approach, which I tend to use for a lot of my cases, you look at acetabular anteversion in the sagittal plane, especially when you position a patient and when you see what is the opening angle of the cup. If you look at a radiograph to assess how much anteversion you have, you will look at it in a coronal plane by holding the pelvis like this. If you are going to assess failure of acetabular components and see whether or not there was enough anteversion, you will get a cross-table lateral X-ray for these patients to see whether acetabular anteversion was restored, or you will get a transverse plane CT scan or a cross-sectional CT scan, and you'll see where does the cup point. Does it point towards the head or towards the ceiling, which is anteverted, or does it point towards the floor, which means retroversion? So for the purposes of this talk, we are really going to focus on sagittal spinal issues and sagittal spinal balance, and that will be defined as our operative acetabular anteversion. So how do we measure that? We will draw a line from the posterior inferior aspect of the acetabulum parallel to the floor. So that's your horizontal reference. And then we draw another line connecting the posterior inferior aspect of the acetabulum to the anterior superior aspect of the acetabulum, and that's defined as acetabular anteversion. And you can see that is pointed towards the front. Now, these are examples of what happens when you go from a standing position shown on the left to a sitting position shown on the right. So notice in both these figures, what's key to notice is that the pelvic incidence remains absolutely the same. Look at the sacral slope. From the standing position to the sitting position, the sacral slope decreases. So if the pelvic incidence has to remain constant, what has to happen is that the pelvic tilt has to increase from the standing position to the sitting position. Along with an increase in the pelvic tilt, there is also an increase in the acetabular anteversion. Now, this is a case of a normal person who doesn't have any spinal pathology or a prior spinal fusion. So this is a flexible spinopelvic unit. And to illustrate this with this model, if you're in a standing position, that's how the pelvis appears. And in a sitting position, that's what happens. If you want to look at it in terms of the acetabulum that I have fixed, in a standing position, your acetabular component is somewhat like this. In a sitting position, the acetabular component appears to be more anteverted and more vertical. So let's look at, that was pelvic changes from the standing to the sitting position. What about pelvic version? Pelvic anteversion and retroversion is a little bit different than acetabular anteversion and retroversion. And I have a wonderful video, again shot at Lyon, showing this. So tilting the pelvis forward as if to give an inlet view of the pelvis is known as pelvic anteversion. Okay, now I'm just focusing on the pelvis in this slide, even though there are some compensatory changes in the spine on how the spine is stressed. If the pelvis is moved backwards posteriorly so that it gives an outlet view of the pelvis on an X-ray, on an AP pelvis X-ray, that is known as pelvic retroversion. So once again, I'm going to demonstrate this with my pelvic model. So if I'm looking at a pelvis straight on in a coronal plane, this is called pelvic anteversion, an inlet view of the pelvis, and this is called pelvic retroversion. Okay, but notice what happens in the sagittal plane as I do that. So in a sagittal plane, I'm holding the pelvis in pelvic anteversion. You can see inside the pelvis. Look at the acetabular component. The acetabular component actually appears to be, if you look at an AP view, it appears to be very neutral or retroverted. So the acetabulum is retroverted. Now, if the pelvis goes into retroversion, so that's an outlet view as seen here, look at how much opening you see in the acetabulum. So now the acetabular anteversion is exaggerated. So how do you define this paradoxical relationship? And this is a simple slide to conceptualize it. As you are standing, so this is your pelvis model again. As you are standing, if you have normal lordosis, you tend to have pelvic anteversion. And with pelvic anteversion, the acetabular anteversion is reduced. So there is relative retroversion of the acetabulum in relation to the pelvis. As you sit down, your pelvis goes into retroversion. So you have an outlet view of the pelvis, but the acetabular anteversion and verticality increase. So it's a paradoxical relationship between the pelvis and the acetabulum. And that is key to understand spinopelvic balance. So where do you put the cup? And this is a video, again, kind of demonstrating standing to sitting position. As you go from standing to sitting, the acetabular anteversion, as we discovered in the previous slides, increases. The average increase in a normal patient is about 15 or 16 degrees. Along with this, you have to understand that the cup verticality also increases by about 20 or 25 degrees. And this is very important as you are placing acetabular components. If you place an acetabular component appropriately anteverted, your cup is going to be slightly vertical. And as you over antevert this in some of these cases, you have to be careful that you do not make your cup too vertical. That is just the three-dimensional nature of the acetabulum. So the corollary to that is that if you are placing your acetabular component in retroversion, the acetabular component will be a lot more horizontal. So just be aware of this as you perform your total hip cases and pay attention to this three-dimensional relationship. Now, pelvic, when you use these sagittal plane references that we define, which is the sacral slope, pelvic tilt, pelvic incidence, lumbar lordosis, what is important to realize that as you do a total hip, really the pelvic tilt does not change. The sacral slope does not change. The pelvic incidence does not change. What changes is the position of the patient when they go from a standing to a sitting position. So the pelvic tilt and the pelvic incidence and sacral slope will remain the same as you're doing a total hip, but what changes are these parameters as the patient mobilizes. So a safe zone that has been determined, a Lewenick safe zone, is about 5 to 25 degrees of anteversion. And if you're doing the Ranawat combined anteversion technique, you should have about between 30 degrees to 50 degrees of combined anteversion. And the concept of combined anteversion is very confusing. So I have a slide showing you this, and this is from Ranawat's publication. What you do is that with the leg in a neutral position from posterior lateral approach, you line up the flat part of the trial head with the flat part of the polyethylene. So you make them parallel or coplanar with the leg in the neutral position. Now, the second thing you do is that you look at the angle made between the leg, so that's between the fibula, and the floor. And that angle should be anywhere between 30 and 50 degrees if you've had good anteversion in the cup and good anteversion in your stem. So that angle should be between 30 and 50 degrees in most cases. You may have to over exaggerate this in some of the spinopelvic imbalance cases that I'll show you, but it's important to understand that this is a check and a balance intraoperatively, and it's a very useful tool to align your components. So again, let's kind of expand on this concept. Where do you put the cup? With 1 degree changes in pelvic tilt, there is about, not a complete degree, but about 0.8 degrees change in acetabular anteversion. So as the pelvic tilt increases, there is an increase in acetabular anteversion and vice versa. With an increase in pelvic retroversion. Now again, pelvic retroversion, as you remember, is the sitting position where you get more of an outlet view. With pelvic retroversion, there is an increase in acetabular anteversion. With pelvic anteversion, there is a decrease in acetabular anteversion. Okay. In a total hip without spinal deformity correction, the biggest problem is a high dislocation rate. So we have to be very cognizant of this in terms of our spinopelvic balance. This is the absolute key principle. So today, if you're going to walk away with anything in this talk, I think you have to understand the balance of the spine on the pelvis and the pelvis further down. And here is a beautiful slide illustrating this. The spinopelvic unit is fixed, but when the pelvis sits on something, it's the femoral head. And there are several degrees of rotation between the pelvis and the femoral head. So this unit, as you see here, is very mobile in multiple different planes, and it is very unstable. So what is the principle that's important in this? Well, the principle is that if your spinopelvic unit is imbalanced, unfortunately, what is going to bear the brunt of this is going to be your hip. So you'll have hip arthritis. Secondary to that, when you do a total hip in these patients, that implant is going to be stressed a lot more, and the risk of polyethylene wear, bearing surface failure, and dislocation is very, very high. And it's because of this, the pelvis is rotating very freely around the femoral heads. Now, of course, there are muscles and capsular attachments that stabilize this, but overall, the least stable place is at the joint, which is the hip joint. So what's the treatment algorithm? Well, in some ways, this is my treatment algorithm, but some of the literature is proving this to be a little old and a little too simplistic, and I'll go over this further on. So if possible, you can get these films called the EOS films. It's a proprietary software and a proprietary hardware in which you get sagittal, standing and sitting spine films, and I'll show you some examples. And if possible, if there is spinopelvic imbalance, do a spine fusion and then put your hip in the adequate position so that you're narrowing your zone of error, you're narrowing your margin of error on where to put the acetabular component. And there is a classification to understand spinopelvic balance or imbalance. So this is the example of this EOS system. It's a proprietary system and it's pretty expensive, but some institutes have it. And you can get a very nice view of how the spinal column lines up with the pelvic column, and then how the lower extremity lines up and where the forces are in this model. Now, what is the spine balance classification? It's very simple. It's a 4x4, or sorry, a 2x2 Punnett square. Most of us will belong in the top left, which is we have a flexible and balanced spine. If we are not fortunate and we have to undergo spinal fusion procedures, especially spinopelvic fusion, we would like to be in the top right, which is a rigid but balanced spine. If we have adult spinal deformity, we mostly tend to be in a flexible and unbalanced spine, so in the bottom left. And from the bottom left, if we have to go somewhere, we really want to go to the top right. We want to be rigid and we want to be balanced. But sometimes, because of issues with intraoperative concerns or because of inadequate correction of the spinal deformity, we end up in the bottom right, which is the rigid, unbalanced category, which is the most dangerous for these conditions. So again, we have looked at this before. What happens in the flexible yet balanced spine? You go from a standing position that looks like this to a sitting position that looks like that. So there is an increase in the pelvic tilt as you sit down. There is an increase in the pelvic retroversion as you sit down, and your cup anteversion and your cup inclination tends to increase. But there is a low risk of impingement in these cases if you put your total hip acetabular component between 5 and 25 degrees of anteversion. So this is the ideal circumstance for the hip surgeon. You can put the cup in Levanic safe zone, and for the most part, you will be okay. What happens in a rigid but balanced spine? So now what is happening is that you have hardware up in the spine and you are fixing the lumbar column to the pelvis by means of lumbosacral or sacropelvic fixation. So now what happens is that depending on where you've been fixed, and ideally you've been fixed with a lumbar lordosis pelvic incidence mismatch of less than 11 degrees, this is not going to happen. You're not going to go from this position to this position as you go from standing to sitting. You're kind of fixed in this in-between position. So there is no compensatory increase in pelvic tilt. There is no compensatory increase in acetabular anteversion. There is no compensatory increase in pelvic retroversion. So if you are in this relatively neutral position for the acetabulum, when you sit, you will impinge anteriorly, and by impinging anteriorly, you will tend to lever out posteriorly. So in that situation, you have to, as a hip surgeon, give the acetabulum more anteversion. And this has been shown in this figure here, where in the extreme right picture, you see where the impingement occurs with the asterisk. And you would want to put the cup in greater anteversion, so about 15 to 25 degrees of anteversion, so that you give them the most likely benefit of preventing anterior impingement and posterior dislocation. And you're also, by giving them acetabular, you're increasing the anteversion, and I'm exaggerating in this case, you're also increasing posterior coverage for these patients. Now, what happens in a flexible but an unbalanced spine? So in a flexible but an unbalanced spine, most likely you are reducing your lumbar lordosis. You have flat back. Okay. So in the flat back, your pelvic retroversion already exists. And to compensate for that pelvic retroversion, most patients will lean forward. So they will have a positive sagittal imbalance in their spine. Now, in that situation, when you are in a standing position, you will have fairly decent acetabular anteversion because the pelvis is retroverted. But when you go in a sitting position, again, you will have increased anteversion. Okay, the sitting position increased anteversion is okay, but in a standing position, then if you have increased anteversion, as shown here, the hip will impinge in extension as somebody stands and will lever out anteriorly. So again, I'm exaggerating the acetabular component positioning just to demonstrate this concept. So in that case, you want to reduce your acetabular anteversion and your cup will be more horizontal. But along with that, your cup will also have only 5 to 15 degrees of anteversion and not 10 to 25 degrees or the higher spectrum of anteversion. So to account for posterior impingement and to prevent anterior dislocation, what you are doing in that case is that you are artificially increasing your anterior coverage of the cup and reducing your posterior coverage so that you do not pop out the front. And ideally, in this flexible and unbalanced situation, you should think about correcting the spine first so that you have a rigid, balanced construct, and then putting the acetabulum in a little bit more anteversion. Now, what if you have the worst problem possible, which is a rigid and an unbalanced spine? Well, this is what we call dealer's choice. Typically you'll have to assess where the imbalance in the spine is. And in most cases, like I showed you in the lumbopelvic mismatch X-ray, there is a flat back. So there is inadequate restoration of the lumbar lordosis. If that happens, there tends to be an increase in posterior impingement and an anterior dislocation. So again, ideally in these cases, you should really consult with your spine surgeon and move them from a rigid unbalanced category or classification to a rigid balanced classification, and then put the acetabular component in increased version. But if they are reluctant or the patient is reluctant, then what you may need to do initially is put the acetabular component in less anteversion, so about 5 to 10 degrees or 5 to 15 degrees of anteversion to prevent posterior impingement. And then once the spine has been corrected, reassess the patient. And if they are presenting with instability of the hip, you may have to do an acetabular component revision, or you may have to end up with a face changing or a lipped liner to give it some more anteversion. So I wanted to demonstrate a case. This was a case from fellowship in which we had a 53-year-old woman who came with left hip pain and she had failed conservative management. She had some evidence of femoroacetabular impingement bilaterally, and she'd had a prior arthroscopy with a labral repair, which had also failed. Injections had failed. She had these comorbidities, but as you can see up north, she also had lumbar decompression and fusion. So we ended up doing a posterolateral hip for her, and we had pretty good leg length correction, pretty good restoration of the offset. The acetabular component looked well placed, but not enough anteversion, one could argue. The night of surgery, she dropped something from the bed and she tried picking it up. And since we had used Exparel in this patient, which is liposomal bupivacaine, she ended up dislocating and not even knowing until rounds the next morning when we found her with this hyperflexed painful position because the Exparel had worn off. We then had to perform this close reduction the same day for the patient. And we got some cross-table lateral x-rays, and I'm going to draw out the acetabular anteversion in this. So you go from the anterior and posterior margins of the acetabular component, and then you draw a vertical line, and you can see that we probably have about 5 or 10 degrees of acetabular anteversion, so not adequate in this case. The hip was still stable. We placed the patient in a knee mobilizer and an abduction pillow. She was made weight bearing as tolerated, and physical therapy was resumed as normal, and she was discharged after a prolonged hospital stay, and there were no further episodes of instability. But what should we have done ideally in this case? We should have gotten standing spine films to especially assess where her spine balance is, because she did not have spinopelvic fusion. She had lumbar fusion, but that means that maybe her lumbar lordosis was not adequately restored, and all of a sudden she has this rigid, unbalanced spine or a flexible, unbalanced spine. And then we should have put the cup in a little bit more anteversion, as I showed you in that cross-table lateral X-ray. Now, if she were to dislocate again, what would we have done? Well, number one, we could have consulted with our spine surgeons if her spinal balance was not adequately restored to correct that. We would have revised the cup to more anteversion. And once the cup is ingrown or used a multi-hole cup, we could have considered a constraint. But then you are increasing the risk of impingement by reducing the jump distance in these patients. So that is not a good solution. Another option potentially is to consider dual mobilities. But if a dual mobility dissociates, then it's no longer a closed reduction. You have to open the patient back up. So it's a complex interplay, as I showed you previously. Now, here is another example of this patient. So this is the best AP pelvis X-ray for this patient I could get in a standing position. And you could see my template. So this, you can argue that if this is an ideal AP pelvis, if you're looking at it, the patient is showing you more of an inlet. When they're showing you more of an inlet, what is happening is that they have lumbopelvic imbalance, or they have sacropelvic imbalance. They have more pelvic anteversion. And as we know from our prior discussion, if they have more pelvic anteversion, they tend to have native acetabular retroversion. So the acetabular version in relation to the pelvis is in a more retroverted position. Now, you can see that there is lumbar pathology in this patient. We counseled her. I had a multidisciplinary consult with the spine surgeons to see if she would like her spine corrected first. But given the lack of mobility with these severely arthritic inflammatory disease, inflammatory arthritis protrudes your hip, we elected to proceed with a total hip replacement first. So in that case, if I have increased pelvic anteversion to begin with, and I have relative acetabular retroversion, what I have to do is I have to exaggerate my acetabular anteversion, because if the patient is going to be held in this position and they go from a standing position like this to a sitting position like this, they will impinge anteriorly and they will lever out posteriorly. So by increasing my acetabular anteversion, one, I'm providing a posterior buttress to prevent dislocation, and two, I'm reducing the risk of anterior impingement by allowing the hip to sit in a more favorable position. So these are the post-operative X-rays, as you can see on the left, where, of course, I had to restore the hip center of rotation by impaction bone grafting from the femoral head to bring the hip out more laterally. But you can see that the anteversion looks excessive, and that's true, as you can see on this three-dimensional CT with the cross-section. So here, if you put this cup, the cup is way pointing towards the ceiling and not pointing towards the floor. So it is way anteverted to correct for this spinopelvic imbalance in this patient. Now, of course, if she chooses to undergo the contralateral hip, we would do the same thing. And if she chooses to undergo spinopelvic correction, then we may have to think if she dislocates anteriorly, but hopefully by that point, she has enough scar tissue to prevent that from happening. Now, this is a unique case of spinopelvic imbalance. This was a 30-year-old woman I saw approximately 2 or 3 years ago. At that point, she was 30 years old. She came in with 10 years of left-sided groin pain. She was otherwise pretty healthy, but she had a surgery for developmental dysplasia of the hip at age 15. And this was done in South America, and we weren't sure what the procedure was, and it was difficult for the patient to explain it. But she'd had failure of non-operative measures. She had severe limitations in range of motion of her left hip. There was a significant limb length discrepancy, and of course, an antalgic and shortened adducted gait. And these are the preoperative radiographs of this patient. And again, you can see that there is something going on which I couldn't really understand besides the, there is of course a deformity in the proximal femur, there's a deformity in the left acetabulum, but there is something going on the spinopelvic junction, and I will describe that to you as we move along. But if you can imagine, her left hemipelvis is held in a very inlet type position, and her right hemipelvis is rotated a little bit in a normal AP pelvis position. So she has this one-sided inlet view and an other-sided, almost a neutral view of the AP pelvis. So there is something going on, and it is lopsided. Again, you see this here. You would look at the hip deformity and you're like, yes, of course, that's a difficult deformity to correct. And probably the procedure she was referring to was a shelf osteotomy to correct her developmental dysplasia. But look at the sacropelvic junction. You have a beautiful SI joint on the right side, but on the left side, it is very hazy and in fact, not even existent. So what did we do? We got a CT scan and that reveals the true picture. On the left side, see, she has sacroiliac fusion. It's an auto fusion, either developmental or something happened during the course of her treatment, and we just don't have previous x-rays to see what's going on. But on the right side, she does have a mobile sacroiliac joint to some degree. So this is something which is very challenging to address in addition to her lumbar lordosis. And this is a sagittal view showing the same thing, where her left-sided pelvis is, or hemipelvis is fixed in this position, and that's what we have to work with. Once again, the CT scan showing that there is no SI joint on that left side. And you can see the deformity of the femoral head, which is fallen into this retroverted position in the proximal femur, along with very less version given to the native acetabulum. So what are some challenges to consider? Of course, the patient age and the further dictation of a bearing surface, the limb length discrepancy, and counseling the patient that, to some degree, her limb length discrepancy will persist because it also involves an SI joint that is autofused, which we cannot correct. And she had a prior infection along with her surgery. So we have to think that even if the labs are normal, and if we find that the frozen section shows high PMNs per high powered field, we may have to consider putting in a spacer in this patient. The anatomic challenges include, in addition to spinopelvic imbalance, a SI joint autofusion, pelvic dysmorphia. So where do you put the cup in such a challenging case? Dysplasia. So we really want to keep that superior shelf. Otherwise, our cup is going to escape superiorly. And then femoral retroversion. So think about this. We just spoke about pelvic anteversion, retroversion, acetabular anteversion, retroversion, but now there is femoral anteversion, retroversion that we need to consider. So how do you account for all these complex things? Well, again, for me, x-rays are fine, and I could have gotten long length spine films, but I don't think that was very helpful in this case. I really wanted to focus on the CT scan, so I created a three-dimensional model with a 3D printer of this construct. And this is the posterior view, as you can see on the left-sided image, and the superior view, as you can see in the right-sided image. Here is the shelf osteotomy, the shelf that I want to preserve, and here is the native femoral head. So I want to, kind of use this in my case to try and preserve whatever anatomy I have and correct whatever deformities I have to correct. Now, this is an intraoperative view, again, from a posterolateral approach, where you see the Gelpi retractor on the right-hand side, that is towards the head of the patient, and my Chanley retractor is facing towards the foot of the patient. And you can see the shelf osteotomy, but look at the native acetabular version. So her acetabular version is in a lot of retroversion. We already saw that her femur was in a lot of retroversion. So if we put a hip in this position, she is, of course, going to lever out the back. So in that situation, we accepted that we would have to over-antivert the cup, and we would have to change the version of the proximal femur, which can be difficult to do. But here are the post-operative functional videos at 2 years. And of course, she has a limb length discrepancy, which was described to her. I said that, look, we could give you a shoe lift, but she did not prefer to use a shoe lift. So you can see this is her ambulatory ability. And this is the ability of her to sit in a squatting position and stand up with complete hip stability at 2 years. And let me show you the radiographs for this patient. As you can see, we've employed the use of the shelf. We've put in a 48 millimeter cup, so that gave us a 32 millimeter head. We used multiple screws because I was afraid of the cup levering out at some point. We were able to restore the position of the hip center of rotation. We could not, of course, correct the leg length because of the SI joint autofusion, but we were able to change the femoral antiversion or the femoral retroversion by using an SROM type stem to give it some more antiversion even in the femur. And then using Ranawat's combined antiversion technique, we made sure that her combined antiversion happened to be around the 50-degree range, between 30 to 50 degrees, and not on the lower end of the spectrum, to give us the correction that we desired. And that has worked really well for her for 2 years. And we were very fortunate in publishing this with some of my colleagues. So, was what I presented very easy to understand? Unfortunately, I don't think so, because I had to think like a spine surgeon, remember my days in residency as a spine resident, and then apply my total hip principles and kind of think about the various different versions that we need to account for. But there are people in the orthopedic community that think that this is still too simplistic, that there is another layer that we need to unravel. And as we progress, that's what we need to kind of do. We need to unravel this as layers of an onion to see where things belong today. So this was an excellent review performed by Michael Mont about 2 years ago. So these are, just I wanted to summarize the findings in his review. So what is the impact of adult spinal deformity, or ASD, on total hip outcomes? And he looked at this, and in the English literature, there have been 3 studies published on this from 2000 to 2017. And the first 2 studies were in ankylosing spondylitis patients with adult spinal deformity, but also with hip pathology. And what happens in these cases is, what they've said is that, the ankylosing spondylitis patients tend to have a lot of pelvic retroversion. Because of pelvic retroversion, they are fixed in this sitting type pelvis, and they have excessive acetabular anteversion, and that creates complications. So the acetabular, if you do a total hip in these ankylosing spondylitis patients and don't recognize this, they tend to have a lot of anterior dislocations and revisions for that. Also, dislocators, the people who dislocate have this higher degree of pelvic incidence to lumbar lordosis mismatch, so more than 10 or 11 degrees. And it's important to recognize that in cases of adult spinal deformity. Now, what if you go ahead and correct that adult spinal deformity by performing osteotomies and fusions? What happens then on total hip outcomes? So these are patients that have adult spinal deformity correction and then a total hip. I said that is my preferred thinking, that we should correct the spine first and then put the hip where it belongs in the pelvis, especially as I showed you that the balance between the spine and the pelvis we can control to some degree, but between the pelvis and the hips is very, very mobile, and that's where the stress happens. So multiple studies in the 2014 to 2017 era have shown that by correcting the adult spinal deformity, by fixing them in a less of a pelvic retroversion, but more of a pelvic anteversion position, you are reducing the acetabular anteversion and you're reducing the abduction. So again, as acetabular anteversion decreases, the horizontality of your acetabulum increases. And by doing this, still by doing long segment fusions as shown by Bedard in 2016, you are still increasing the dislocation risk. And there was only one paper that threw their hat in the ring and said, no, you should still correct the spine first. What about previous spinal fusion on total hip outcomes? So now it wasn't necessarily a fusion done for spinal deformity. It may have been a fusion done for a degenerative process or a herniated disc and some form of instability. Again, in all these studies, what has been shown is that there is a higher risk of dislocation after you do a total hip in these spinal fusion patients, because that lumbosacral junction and the sacropelvic junction is too stiff. So the hip is seeing a lot of this force. And if you increase the levels of fusion, you have increased risk of dislocation. So what should we do? Should we do a spine deformity correction and a fusion in these patients, or should we just leave them in imbalance and perform a total hip? So what is now emerging as we think about this more is that there are muscles that play an important role, especially when you're talking about pelvic anteversion and retroversion. So in pelvic anteversion, if you have, and I should demonstrate this to you with a hip, with a femur model, if you have pelvic anteversion like this, and that is fixed in a patient, they tend to have a hip flexion contracture. They tend to hold their pelvis in an inlet type view. They tend to have a flexion contracture or also an adduction contracture. And let me demonstrate that to you with this slide. So as the pelvis anteverts, there is a hip flexion deformity. As the pelvis retroverts, there is an extension deformity in this pelvis. So you can see that there is anteversion happening. The pelvis is fixed like this. Now, if in that case you do a spinal fusion and you fuse the spine like this, your pelvis is also going to be fused in increased anteversion, and your cup is going to be retroverted. So then you would tend to exaggerate the anteversion of the cup. But instead of that, what if you did this? And this is the proposed algorithm. So you assess the patient. If they have hip osteoarthritis and an adult spinal deformity, look and see if they have a hip flexion contracture present. And you can do that very easily on the table. If they have a flexion contracture present, so you go on the left side of this algorithm, then what you do is you go ahead and you correct this hip flexion contracture by performing a total hip. So now, instead of the pelvis being anteverted like this, you are putting the pelvis in a more mobile area, somewhere between retroversion and anteversion. So somewhere here. And then you look at the spine. If after correcting the hip and correcting the pelvis, your spine has compensated for it and gone from an imbalanced to a balanced spine, then you can just monitor it, just look at it. If it is still an unbalanced spine, then you send them for a spine surgery consult and you do a deformity correction with a potential for revising the cup in the future. But let's say you do not have a hip flexion contracture present, and that patient says that, I have these 50-50 symptoms, but really I think that I have this radicular pain. Then what you want to do is you want to perform the spinal correction first, figure out where the spine balance is, and if the hip becomes symptomatic, then do a total hip. And in that case, think of it as a rigid and balanced spine. So in a rigid and balanced spine, you are fixing it in relative pelvic anteversion, and your acetabulum is going to be retroverted. So in that case, you go ahead and you put the cup in a higher degree of anteversion. Now, if they do not have a hip flexion contracture and they tell you that the hip is more symptomatic, in that case, again, perform a total hip, put the cup in relative anteversion, and tell the patient that you are at increased risk of total hip complications if that spine deformity progresses. So the new method of thinking is, don't just willy-nilly fuse the spine first and then do a total hip. Assess the patient. You don't need any kind of complex long length films like the EOS films. Look at their hip, look at their flexion contracture, correct their flexion contracture as you perform a total hip, and then look at their spine and come back and address the spine. So with that, I'd like to thank you very much for your attention. I know this is a complex topic, especially on a Sunday evening, but thank you very much. This is the Johns Hopkins Hospital as it stands today. And I welcome you to come and visit us and come work with us, and hopefully we can learn from you as well. And this is my contact information. Thank you very much.
Thank you, Savya. That was a splendid lecture once again. And it was very nice listening to you. Of course, it's a very, very complex topic, and it's only off last 110. There's a lot of discussion on this. Until then, it was just you treat the spine first, isn't it?
Absolutely right. Absolutely right. And, we are extending this concept a little bit more, because if you have a loss of lumbar lordosis, you have a flat back, you have pelvic retroversion. To compensate for that, patients lean forward, have positive spinal imbalance. Now, we are only talking about the spino-pelvic junction and the pelvic hip junction, but look below that, look at the knee. Now you have a knee flexion contracture developing as well. So this extends further down the spectrum.
The algorithm that you mentioned, that you quoted with the Journal of Arthroplasty 2018 by Sultan, if you look at the 4 different options, for the first 3 say that you treat the spine first, and only in the absence of a hip flexion contracture and with the symptomatic hip, you address the hip first, isn't it?
Absolutely correct. Absolutely correct. I think what the principle that they are trying to highlight is that there are certain things that you can correct, obviously, with your total hip, but you really want to engage your spine surgery colleagues early, because in a lot of these cases, the spinopelvic imbalance can be more complex than just 3-4 levels of correction. They may have to look at an entire picture of this patient and really counsel that patient that, look, we can do this in a staged approach, but A, we may need to alter the surgical approach that we use for you, especially as a hip surgeon. And B, we may need to perform revisions for you to prevent failure of these prostheses.
Yeah. The other thing that has come up is, see, you showed an X-ray of a protrusio with a increased pelvic anteversion. Right? And in that particular view, it appears like a pelvic inlet view. And those are the patients who are at risk for acetabular retroversion and posterior dislocation. Am I right?
Absolutely.
And in those cases, you try to keep the cup anteverted slightly.
Correct.
The same thing applies vice versa. If you get an outlet view, you are having a risk of anterior dislocation, and you're going to keep the cup slightly posterior. Am I right?
Absolutely correct.
Okay, I think so. Basically, we can just have an idea by looking at the pelvic AP radiograph, isn't it?
Absolutely. And as hip surgeons, I think that's what we're inclined to do.
Because you know what, as a hip surgeon, if you talk to them about pelvic incidence, sacral slope, and pelvic tilt, they will not
be very confusing.
They will not be very comfortable unless you're a spine surgeon. So I think a very useful tip is that pelvic radiograph, AP radiograph. If it is anteverted, if it looks like a inlet view, risk of posterior dislocation, you keep the cup anteverted, right?
Absolutely. And even in those cases, what I would argue for is get a standing AP pelvis view. Always standing x-rays, weight bearing x-rays, because sometimes when they lay down, things change completely for you. And then, again, your references are gone. But and you have to recognize this, if they are they're obviously laying down on your operative table, and if you're doing an anterior approach, all of a sudden, if that pelvis goes into more retroversion and the acetabulum appears to be more anteverted, that can fool you. So you should recognize your standing x-rays and template off of those.
And with respect to that particular X-ray protrusio, where you have a pelvic inlet kind of view, what would you expect when you take a supine and sitting and a standing? Was that a standing or a sitting X-ray?
That was a standing X-ray.
And in that particular case, what would be the supine? I mean, sitting X-ray, how would it change?
And again, part of this is observation. And I think that, as we examine patients, I like to have them sitting. I like to see them standing to see where they are. I don't have X-rays. I don't necessarily get EOS X-rays. But if they have a balanced spine to some degree, you may have some change. So as you are going from here in a standing view, you may have some correction of that in a normal pelvis or a balanced or a flexible spine. But in her case, given the amount of arthritis, it was fixed in this position because as she was sitting, she was lurched way up in the front like that. So I think that was important to recognize in her that, if she's sitting like this and I do a posterolateral approach, she is going to go off the back.
Okay, I think, and see, suppose in that particular case where we have a same increased pelvic anteversion, increased risk of acetabular retroversion and posterior dislocation, do you think if we approach it using an anterior hip surgery is going to have a benefit?
Yes. So, there is a lower risk of dislocation with an anterior based surgery. You're not, affecting the posterior capsule, so you're keeping that intact. But there are two, suggestions that I have for that. One, you have to be facile. You have to be comfortable doing an anterior hip. If you do it very less, then you risk in destabilizing the femur, especially as you're doing the femoral releases. So you have to be very comfortable doing that. Two is that you have to really position that patient carefully and keep assessing the position of the patient with the anterior approach. If I am doing an anterior approach, I tend to use a lot more x-rays to keep confirming where the position of these components are, because I do not have the ability to perform a complete range of motion analysis as I do with the posterolateral approach. So in my hands, I still feel more comfortable assessing limb lengths, offset, combined anteversion, anterior and posterior instability from a posterolateral approach. So in my hands, I would still do a posterolateral approach for that patient as I showed you.
And do you think a navigation would help in improving the accuracy, reducing the risk of dislocation?
Yes, so that is fantastic. If I learned a little bit of computers growing up, and there's this term called GIGO, which is garbage in, garbage out. And the important thing with that is that if you use navigation, be very careful about your pelvic referencing. Maybe get a CT scan, maybe compare that, maybe, and you can take it to the next step forward. You can use a Mako or some kind of robotic system if you have access to it to really understand your pelvis. But if you don't have access to these, then I think that the Ranawat combined anteversion trick is essential. And if you learn that, you will very rarely make a mistake in aligning your components.
And do you have a computer-based surgery at Johns Hopkins for joint replacement for hip?
So yes, so we do have a navigation system, and we are in the process of getting a robotic system.
Okay, the Mako.
Mako, yes, but also the Smith & Nephew has a robotic system called the Navio. So they have a hip application, and that's what we're looking at as well. And
the other thing was, you showed the coplanar test or the Ranawat combined anteversion test. It was really nicely explained. And is it the angle that the leg that's subtended with the horizontal, is that the angle that you're talking about?
Yes. So as I'm going to try and demonstrate this with this, hip model. So if I am like this, my hip is reduced here, okay? And if my tibia fibula were attached to the knee in a posterolateral approach, what I would do is I would look at the angle that the tibia fibula make with the horizontal or hopefully the floor. And that will be the angle which gives you the coplanar or combined anteversion angle.
And it should be within what is the normal range it should be?
Yeah, so that's between 30 degrees and 50 degrees. So if you think, let's say you put your acetabulum in about 15 degrees of anteversion and your femur in about 15 degrees of anteversion, 15 plus 15 is 30 degrees of combined anteversion. And let's say you go to the higher end of the spectrum. You say that I have someone with lumbopelvic imbalance and I want to put them at 25 degrees of anteversion in the acetabulum and 25 degrees of anteversion in the femur, as shown by that extreme case at the end. Then my combined anteversion should be 50 degrees. So that's why the range is between 30 and 50.
So in that case, once you've made once you put the trials, your leg the tibia should be at 55 degrees with the horizontal.
Correct. So if this is the tibia fibula, my forearm, this is the floor, that's the angle that I'm making there.
Okay. Okay, so that's all the questions we have because it's a really tough topic, and I'm sure even I have to go through the lecture many times. The very important example that you quoted was the protrusio, and that is one that I remember so clearly. That the concept of anteversion and the risk of, concept of pelvic anteversion, risk of acetabular retroversion, and then you look for an increased anteversion for the cup. I think that's a very important case example that you've shown.
Absolutely. And I think, as a trainee surgeon, I was very confused when I would go into a case and my consultant or my attending would say, what is the version? I'm like, well, the version of what? The version of the pelvis, the acetabulum, or the femur. So you really have to tie these concepts together and understand that one affects the other, affects the third. And I haven't even gone to the knee yet, but if we include the knee, that adds a layer of complexity to these cases. And it requires a lot of planning and in some cases, some experience to deal with these challenging patients.
Okay, Savya. So thank you so much for joining with us, and we look forward for more lectures because it has been fantastic. Your perspective about joint replacement and the surgery in detail. I mean, it's going to be so enlightening for a global audience, I'm sure, because you're sitting at John Hopkins, you're at the best center. I'm sure everyone is going to get the top class experience from your lecture. Thank you once again, and we look forward for more from your side.
Thank you very much for inviting me. Thank you.